Welcome back to Afri-CAN. One of the development issues that we haven't tackled yet on the podcast is healthcare. Yet it is a key aspect of Pharaoh Foundation's productivity mission. It is quite obvious to us that no one can be productive in conditions of ill health. And so we focus on two aspects of healthcare. The first one starts from the view that healthcare starts with a correct diagnosis. So we created a diagnostic center in the remote region of Benishangul Gumuz in Ethiopia, which we are now replicated through our Pharaoh ventures across Ethiopia and Somaliland. In addition, we've become increasingly aware of the fact that non-communicable diseases, so-called NCDs, are a silent killer in East Africa. So we opened an NCD center in Hargeisa, Somaliland, and we've engaged in awareness raising around NCDs in both Somaliland and Kenya. But beyond the confines of the foundation, today I want to explore how we can optimize and increase access to healthcare through innovation in contexts which are resource poor, such as Africa. And towards this, I've invited two inspiring guests. Niek Vesteegde is a tropical doctor turned medtech entrepreneur and the founder and CEO of Goal 3, a social enterprise dedicated to transforming paediatric and neonatal healthcare through scalable, sustainable, and data-driven solutions that are fit for context. After working as a frontline doctor in Tanzania, where he helped establish a neonatal high care unit, Niek saw firsthand the urgent need for innovative solutions to improve care in low resource settings. Driven by the philosophy of achieving more with less, he spearheaded the creation of Impala, a groundbreaking end-to-end patient monitoring solution that does three things. It shifts hospital care from reactive to proactive care, and we'll explain that in a minute. It unburdens health workers and significantly reduces child mortality. Under his leadership, Goal 3 has expanded operations across Malawi, Tanzania, and Rwanda, forming impactful collaborations with health ministries, NGOs, and global health institutions. Niek actively advocates for smarter, evidence-based approaches in global health to make high-quality healthcare accessible where it's needed most. As for our second guest, Alef Meulenberg, he is the co-founder of Rhiza Babuyile and Rhiza Holdings, which implements an innovative, sustainable developmental model in disadvantaged African communities. Its aim is to ensure self-sustainability of these communities and beneficiaries, which is very similar to what we want to do. It implements projects relating to health, education, skills development, and entrepreneurship in the townships of South Africa and Ghana. Alef holds board and executive positions in organizations that are on the front line of implementing socioeconomic change in African communities. He has direct experience in countries such as South Africa, Ghana, Uganda, Kenya, Rwanda, Mozambique, India, and Brazil. So we'll kick this conversation off with a question to Niek. So Niek, the vision of Goal 3 is to be a leading operating software platform for digital diagnostics, e-health, decision support, and data-driven services provided as a service. Could you tell us specifically about your Impala solution and how you see data management and technology opening up the possibility of democratization of healthcare?
Thank you for an excellent question, and of course, thank you for having us on the podcast, Alef. It's a pleasure to be here with you together. I really admire the work you're doing, so happy to share the stage. So maybe to keep it simple, I'm a doctor, and I think one of the key challenges I face is about how do I assess how a patient is doing. And I'm I'm very well trained. If you put it in international standards, I did 6 years of med school. I did training as a tropical doctor for 3 years, as a general practitioner for 3 years. And I still find it difficult to assess how children are doing, what the risk is, where they are. And this is very important, right? Understanding how sick a child is and what the chances that it may go wrong is key to making decisions on how patients should be treated and where they should be treated. And I think it applies to communicable disease. There's also non-communicable diseases. It's about understanding how the patient is doing and how it should be treated. And I think this is where the position of our platform comes in, is how do you make sure that you gather the information that you need, analyze it, process it, and present it in such a way that people can understand how to make decisions. And this is what the Impala system does. So although indeed our focus on the long term is really on the software side and the data side, right now we provide a comprehensive end-to-end solution in which a continuous vital signs monitor, which was specifically designed for this context and for usability and user friendliness, is connected to a on-premise server, which has a backup power supply, which is really, plug and play, basically connected to an application, which is in the hands of health workers to assess not just of one patient, but of the whole ward, which are the most critical patients, which are the less critical patients. In other words, helping them to focus their attention on the patients who need it most. And this is really key because as a doctor working in this environment, as a nurse working in this, you're continuously swamped with work because there's way more patients than you would have in a Western setting. They're sicker, you have limited options, and it forces you to come into a reactive state. So you respond basically when you see an emergency, not able to act earlier. And that's less effective than when you do it earlier. It's more time consuming, it's more costly. So in other words, with the Impala system, by creating that as a platform, we really want to first unburden these health workers, help them to provide them with the information that they need to allow them to take decisions. And once this system is there and once it's operational, you can add new layers of decision support and tools on top of that to help these health workers further and make that more available across more settings. And that's really how I believe we can democratize healthcare. Starting right now in hospitals, but over time, we really want to expand our platform to really reach end to end. I always call it closed loop from the moment they leave home, basically to seek care to when they arrive back home. That's our ambition in the long term. Of course, building it brick by brick, not everything at once.
Amazing. That's a great and simple explanation to a majorly complicated process, I'm sure. Thank you, Niek. So following up on that, I saw that the results from your first pilot in Malawi showed that admission time in the children's ward fell by 26% and mortality dropped by 61% after you introduced Impala, which is amazing. When Faro Foundation opened a neonatal ICU in Asosa Hospital, we also had strong results with respect to infant mortality. And, to some extent, obviously, in these kinds of environments, any intervention makes a dramatic difference. But I think that the numbers that are coming up here on your side are particularly strong. The key for me and what you're doing is, and what you just partly said in the previous answer, is the way that Impala allows for a transition from reactive to proactive care. And I'm really interested to hear, how you see that process happening in particular.
Yeah, no, thanks. And I think this is indeed key. So the data on the pilot is a bit outdated, but I'm happy to share that the results in a lot of ways are actually getting stronger. So we have results from more settings on workload reduction, on mortality reduction, on cost savings, actually. So if I summarize it, mortality rate drops by 20 to 40% across neonatal and pediatric care settings. If you express this in a cost per life year saved or cost per life saved, then the cost for ranges between $100 and $200, which is extremely good if you benchmark that against other interventions, because it's more effective than standard of care interventions like artesunate for malaria treatment for pneumonia. And on an international level, it's even better because if you benchmark it against Malaria Foundation or Vitamin A, which are top-notch recommendations made by GiveWell, which focuses exclusively on cost effectiveness, they're around $5,000 per life save. So meaning that we are by a lot of numbers better than what it is. And of course, although it's early, we're still building the evidence. I think it's very consistent and strong in what we have. And I'm confident that moving forward, it will only become better, actually, because we also continuously invest in the platform, in the technology and building. And the reason for that is we streamline the whole care process. This reactive to proactive care is streamlining the healthcare process. It's breaking that vicious cycle of reactive care in which health workers are constantly running from one emergency to another, or to a situation where they're more in control, where they're unburdened, where they can recognize these conditions, act on time and whatsoever. And this is what the other element that we see reflected in our data and the surveys that we have done, that health workers after implementation report a reduced workload. And that's quite rare, because most things are focused on improving quality of care actually just adds to the workload. And this is really about the philosophy of achieving more with less. I was in that situation. I was within a year, I felt be a burnout because I had to work in such a stressful environment. So it's about how can we achieve more with the scarce resources that are there, because that's a given. There won't be more resources for the years to come or whatsoever. If it increases incremental, well, we would need maybe 5 times more, 10 times more to achieve what we want to achieve. So it's about working smarter, not harder. And then maybe the last aspect, which is even more astounding, I think, in what we're achieving, we have strong data on cost effectiveness in a before-after comparison, now showing that we save significantly more money compared to standard of care. So in other words, working with Impala is costing you less money than without Impala. And I think that is really what it's about. And this transition from reactive to proactive care is about streamlining the care process and providing health workers the tools that they need. And I think that is really the major thing that we're working on to really achieve with our team and with our partners in the countries.
Extremely impressive. Thank you, Niek. Now, moving on to Alef, my sense is that, you're equally keen to democratize access to healthcare as Niek is, but you seem to do it less through technological innovation, more through the force of human entrepreneurship. I think your approach is quite similar to Pharaoh Foundation's in many ways, because, healthcare is seen as a critical input into productivity for you too. And I think you also believe in empowering communities to become entrepreneurs, which is a big thing for us. So in South Africa, you set up both mobile clinics and bricks and mortar clinics. They bridge this gap between, the public clinics where they cannot meet the demand of an exploding population, and private clinics, which are financially beyond the means of most township inhabitants. So exactly who are your target patients on the demand side, Alef? And on the supply side, how do you empower unemployed or underemployed nurses to become these nursepreneurs, as you call them, and run these clinics?
Oh, thank you, Francesca, for the invite to participate in this, and for your bravery to try to pronounce all these Dutch surnames, which can be a little bit of a hassle when it comes to breaking your tongue. But
thank you.
And yeah, Niek, equally very excited to share a platform with you and the innovation around Impala, which was really fantastic. Francesca, back to the question. For us, healthcare is we call it kind of the backbone of society in a way. Is that when you're healthy as a young person, you can finish education. It enhances educational quality and educational outcomes. But it also provides for an opportunity to create a sustainable livelihood, whether that is through entrepreneurship or through employment. So for us, healthcare was added in 2015, so it's almost about 10 years now. We started Rhiza in 2010, so we just turned 15 as an organization a few days ago. But for us, healthcare, thank you. For us, healthcare has been instrumental into achieving other outcomes, so relating to employability, relating to job creation, and relating to entrepreneurial success. So in that setting, we set up mobile and fixed clinics. And mobile clinics are targeted for people in rural communities and in urban communities where you can go to specific spots where there's a concentration of people. So think of schools, churches, preschools, those kind of things, where we want to have a catchment area of a number of students at the same time with a specific focus. So at schools, then this can be sexual reproductive healthcare, or it can be at younger age schools like early childhood development. We can do weight assessment, nutrition assessment, whether the children are vaccinated or not. So in general, our healthcare program is really around providing access for people who don't necessarily have access to quality primary care. And by doing so, to take away part of the burden of the public sector. As Niek was saying, in the sectors that we are in, or the countries that we're in, and the areas that we are in, public sector is significantly overburdened with patients. So and therefore cannot always provide an accurate diagnosis, or is overburdened when it comes to the amount of patients they see per day. So we take away some of that burden. And then with regards to the more fixed clinics, which we call empathy clinics, those are the nursepreneur model that you were speaking about earlier. That's a private clinic that is significantly cost effective for the patient. So we normally charge anywhere, depending on the geography, anywhere between $1 and $10. And those run independently. So I normally tell our team, I call it the bomb test. So what if a bomb drops on our office? Will any of the things that we are implementing still be able to continue without us being there? And that's the idea when it comes to empathy, is to ensure that all these clinics run sustainably financially. And yes, we provide input when it comes to that, but the main aim is for them to run financially sustainable and to provide high quality primary care. So the target group in that sense is slightly different than the mobile clinics. It needs to be people who have some sort of income, whether that is through a social grant in some cases, or in other cases it can be through national health insurance that they're covered for that income. But the nurse need to generate an income to be entrepreneurial, and that's often how we train them as well.
Makes sense. And Alef, how do you ensure that the nursepreneurs are sustainable enablers of this health democratization? Sorry, how much training and follow up do you engage in with them?
So they normally go. Thanks for the question, Francesca. They normally go through a 1-year incubation program with specific targets per quarter, and that incubation program really focuses. It doesn't focus at all on healthcare, ironically, and not like Niek. I'm not a healthcare professional. I studied economy, so I'm one of those people that trying to make sense of it financially. So, but the thing for me is we understand that the healthcare professional has been trained in healthcare. Yes, we can provide them with tools like Infalo or other kind of tools that can advance them when it comes to making the right decisions in healthcare. But we take a baseline level of that. So what we do realize is that a nurse is not typically an entrepreneur. They're not trained to be an entrepreneur. So we train them in that component specifically. So how do you run your business? How do you separate personal finance from business finance? We help them with marketing, with financial, with budgeting, with HR, with all these kind of shared services that they would not technically be able to do on themselves. So we help them with suppliers and with procurement, and have good procurement deals with other organizations. From an equipment perspective to a medication and consumables point of view. So we make it easier for her to run her business. And at the same time, our aim is that she can have a better financial output than what she would have as a salaried employee. And that the clinic eventually becomes hers. So she pays the initial infrastructure over a period of time, and then it's up to her to retain main part of the network, or if she wants to branch off completely on her own. So that's kind of how we empower a nurse to democratize access to quality healthcare.
Fascinating. Okay, so I guess I'll wrap up with the question to both of you. Yeah, ultimately, both your approaches result in increased productivity in the way that healthcare is delivered. I guess goal through is improving the management of these overcrowded emergency contexts, while Rhiza is finding innovative ways of tackling those who've been left out of public health facilities. They're both, I think, equally transformational. But the next thing that I kind of think about when I hear good ideas like these is I'd love to know how they're being funded and what their funding needs are today. So first of all, I was wondering if either of you could tell us a bit about how investable African healthcare is in terms of return on investment in general, and then maybe each one of you can comment on how your initiatives are funded and whether you need more funding.
Yeah, maybe Ella first as a comment. Great story, and I think health professional and economics should talk a lot more together. And
Yes.
I always, and this is what I maybe it's also the bridge to the topic of the question. So in a way, how investable is it? If you look at how big the market is, there's a lot of spending in healthcare. So how can we approach it like it's a loss from a business perspective? There's billions of dollars in each country going to healthcare, and it's about I think making it more efficient. I think that's basically what my starting point was, achieving more with less. So in a way, I see it as an economic unit. I have an interest in economics in general, but it's an economic unit. And how do you increase the productivity and outputs in relation to the resources that you have? That's the main question that we should ask ourselves. And sustainability, having a business model for that is basically essential for sustainability. And I think that is what Alef provides through Rhiza, is creating the environment in which people who are not trained and do not have the fascination with economics that I have to be successful as an entrepreneur, which is a requirement for sustainability, and actually is a way to translate value that you deliver for your patients into something that can be built and grown over time. So, and I think that's really beautiful about what you're doing. Is it's very well thought through, and also thinking of the aspect not how to help the individual, but how to create something that's scalable. So I really admire that. So in a way, I think if you just look at the market of healthcare in Africa, it's big, it's booming, the economics are rising. Yes, it's investable, but it does work differently than other sectors. So in a way, I think sometimes we're, as an innovator, you're sometimes struggling because people don't understand the concept. The people who have the money are not necessarily the ones who understand the public healthcare in Africa, right? So if I would follow the advice of all the investors I've talking to, I would be focusing exclusively on private healthcare in Kenya or South Africa right now. And without trying to be rude here, I'm not doing that anyway. That's not where the problem is I want to solve. Entrepreneurship is a means, a business model is the way to keep it scalable and sustainable, and that's how we do it. So I think in a way, how has Goldtree been funded and what is it to the funding? So first of all, we have a compelling story. I know how to tell it, and people are really willing to make impact and help others. And I think many people believe in the business mindset of transforming healthcare or health systems or whatsoever. So that really helped us to get us going. And then there were different funders. Faro is not one of them, but could have been one of them, to help us to get on this path, to prove that we can make a solution that works. And then there's, maybe a cascade of how things are funded. Right now, we have a blended model in which, because we target public health systems who don't have money, who have long procurement cycles, which we work with philanthropy, ODA, NGOs to get the initial steps funded, the initial projects. Also, really to make sure that we can also come in the hard to reach areas or in places where there's not much resources to start. And then because of our intervention and how it works, it saves money to the health system, right? So in a way, after time, the hospitals can pay for the recurring service fee, which is the sustainability element. So how do we then keep it sustainable? and that it provides a channel also for software updates, upgrades, increasing the value of the system over time, making sure that it remains operational over time. And that's kind of where I see we gradually will transition from right now philanthropy, ODA-driven NGOs, increasingly to working directly with governments, because ultimately, well, it's cheaper to work with us than to work without us. So that's really where we aim for, to reach that tipping point together with the partners in the ecosystems, because I think the ecosystem partners like Farewell, but also Gates Foundation, other partners are really instrumental of achieving this change and accelerating this change, because the change was needed yesterday, not tomorrow or in a few years from now.
Absolutely. Alef.
Yeah, Francesca, thank you for that question. I think equally to Nick, what Goldtree and what we are doing is we're trying to create market access where there was a limited market access before to particular products or particular services when it comes to primary healthcare or specialized care. And the only way to do that is by making it relatively more affordable. And I think that's what Nick and Goldtree has done really well with Impala, and that's what we're trying to do when it comes to our clinics also. So that makes it investable because of the model, because there's significant demand. And if you have a product that you can put into a market at a cost that a consumer can pay, and again, I'm speaking very economical terms and I'm realizing that, but then you have a market there. And I think that's essentially what's proven the model. And then anecdotally, like we had a conversation yesterday, and this has never been our intention for someone who wanted to buy into our business. And I was like, oh, interesting. So someone sees this as a potential to actually get a commercial and social return on. And that's never been our aim, and we haven't set up that way. So, but it does show that there are people who are interested in getting equity stakes into organizations like this. And another anecdote, one of the larger or Dutch technological companies we own shares in, because of the value that we provide from a purpose and from a commercial return to them in South Africa, and those shares were donated. So there are definitely ways in order to invest in healthcare in Africa at the moment. And I think Niek and ourselves are funded by some of the same organizations which are Dutch from a philanthropic point of view. And think of Contribute Foundation as one of the family funds that are really instrumental for us. And I think we're also backers of Goldtree, and some of those kind of organizations that I think are currently funding. Our model is similar to Niek's. We have an NGO and a for-profit entity in order to blend it and work with governments around national health insurance, but also ensure that we have some freedom when it comes to operating privately and therefore providing services that are what we feel are required based on market research. And is there more funding required in the sector? I think there's definitely, and the answer for that is definitely yes. And from a scalability point of view, we want to reach about 1 million patients per year, and we're about 10 to 15% in when it comes to that. So there's definitely more funding required in order to get there. I'll keep it brief, but thank you for that, Francisco.
Yeah, no, it's great to hear all of this. Honestly, it's been an absolutely fascinating discussion. I think we are all probably going to have to learn to speak Dutch, because you guys are doing great things and really taking over this healthcare space beautifully. So next up on our Afri-CAN podcast, we want to look at specific development programs and draw conclusions as to what made them successful. So in our next episode, we will focus on the area of early childcare and education, and look at a specific program called Saving Brains. I'm not going to tell you more about it so that you actually do watch the episode. But yeah, please stay tuned. And thanks again to these phenomenal guests we had today. It's been a great, great discussion. Thank you.
Thank you, Francisca. Thanks, Niek.
Thank you, Francisca.